Welcome everyone to today's webinar with the Accountable Care Learning Collaborative. My name is John Pullman. I'm the Executive Director of the ACLC and I'll be moderating today's call. I'm in the room actually with our two co-chairs, Governor Mike Leavitt and Dr. Mark McClellan in Salt Lake City, Utah, and it's nice to be together in the same location. We also have the Leavitt Partners political expert, Clay Alsbach. He is rightfully located in Washington, D.C. today. He'll be able to give us a little briefing at the beginning and as well as answer some questions. As always, just want to hit a couple housekeeping items. For those of you who've dialed in, please mute your line. If you're using a phone and computer, it's best to do the dial-in first and then connect via audio. Today's webinar is really a conversation. We wish we were all in the same room. We can't be, but there's a Q&A box in there. We have some questions drafted here, have received a couple as well, but please submit your questions and we'll add it to our dialogue. We have a number of guests or a few guests on the line today, and you're also welcome to submit some questions. Let me just note that we do have a number of events coming up, a webinar next month getting into state initiatives, of course our June work group calls, and would like everyone just to note and keep on the calendar October 4th, the next member meeting, and we'll send additional information out there soon. So our time is short. We want to be efficient here, but before we get into some Q&A with Governor Leavitt and Dr. McClellan, Clay, I'd like to turn it to you just to give us a quick briefing on what's going on in the congressional landscape. Clay is now a principal at Leavitt Partners, but formerly and recently he was the chief health counsel for Chairman Fred Upton of the House Energy and Commerce Committee, and is pretty much daily up on the Hill and learning more of what's going on. So why don't you lay stuff out? I've given you the opportunity to present one slide, and I'll present that as you get to that point. Clay?
Sure. Hey, thanks, John, and it's great to be with everybody. And if you want to click to the slide, John, that would be great. So quick update on kind of where we are. As everybody knows, the healthcare policy debate is being dominated by the American Health Care Act and the repeal and replace that the Republicans on the Hill and in the White House are trying to put forward. So what I'll do is I'll lay out just 5 quick updates on key points, just as kind of where we are. The first is Senate Republicans are negotiating as we speak to try to put together legislation. It's only Republicans. There have been some rump groups that have formed in conversations, but it's our expectation this will continue to be a partisan exercise. A second key point is that Senator McConnell, who's a leader of the Senate Republicans, he has told his members that he wants to move forward to a vote before the August recess, so likely in July. And he wants to move forward no matter if they have the votes or not. So there is a date certain in his mind, and he wants to move forward. And that is something that's driving a lot of activity, as you might imagine, in the Senate. The third key point is that there's been a lot of conversations about the American Health Care Act and issues related to the bill. One key point is the bill is going to change. I think that, as you've heard from Senate Republicans on the conservative side, the more moderate side, they all have issues with the bill. And so they want to make changes, whether that's to make the tax credits more generous or to make changes in the Medicaid side to give states more time to unwind their expansions or to make the per capita cap more generous. So they're going to make changes. The question remains, though, as they likely want to throw more money at some of those policies, where that money comes from. Because last week, this is the fourth point, when CBO came forward with the estimate, they said that the House bill saves $119 billion. And under the reconciliation process that the Republicans are following to try to pass this bill, the Senate has to meet and match basically the deficit reduction number that's in the House bill. So they have to save $119 billion too. And that leads to a question of where that money is going to come from. It's our expectation that that money is likely to come from or could come from changes in the taxes that are repealed. So whether that's the investment taxes or some of the health IT tax or device tax, those are some of the provisions that could change because of that, the need for more money in other places in the bill. And then finally, I'll just wrap up in that In this audience, for this audience, obviously delivery system reform, value-based payment is very, very important. And one of the key insights, and just to remember as we look at this, is that the AHCA is not likely to touch that. So they aren't going to make changes to CMMI. They're not going to try to disrupt anything that's going on in that area. And I think that's, as much as there's a lot of change, a lot of uncertainty around what's going to happen in the individual market or around the taxes or some of the Medicaid pieces, that same uncertainty does not apply to value-based payment. So thanks, John. That's all I have, but happy to answer any questions as we move along during the webinar. Thank you.
Thanks, Clay. Appreciate you that briefing and sticking around. There's a lot to digest there. Why don't we switch to the executive branch and ask a question while people are digesting that, and pop in with questions that we can come back to. Mark, I want to look to you first. There's just a lot of uncertainty still on how the administration is viewing these value-based payments. We're starting to see some actions, including some delays of mandatory payments. Even this last week, it was delayed a second time on these bundled payment programs. We're all sort of wondering what can we infer from these decisions, and is there are things that we can plan on going forward?
Yeah, great question. And I think there's obviously a lot of reasons why people are worried about uncertainty in the current environment. I hope we can come back to the implications of the legislative uncertainty. What I don't think people should be uncertain about is the new administration's commitment to the concept of value-based payment reform. Dr. Price has spoken out publicly in favor of continuing a lot of reform efforts. I recently just did an event with Seema Verma where she was very clearly supportive of the general push in the direction of value-based payment reform. And in light of what you just heard from Clay, you can understand why. The Republicans really need to find savings in our healthcare system to make the Medicaid reforms, the other reforms, more likely to take, and to help their efforts going forward on controlling federal costs and supporting reforms in federal payments. What I think is more cause for uncertainty right now is what exact form the new payment reform initiatives are going to take under the new administration. And you highlighted, John, now a couple of delays in certain aspects of the mandatory bundled payment programs. And Dr. Price has been pretty strongly on record in the past as not wanting to do things through a mandatory approach. I think that's where you're going to see a bit of a slowdown, maybe less reliance, as you saw in the last administration, on mandatory shifts into new payment models for hospitals and other healthcare providers. At the same time, he's also signaled a real interest in additional reforms and additional opportunities for healthcare organizations to adopt value-based payments through more voluntary mechanisms. That includes a continuation and potentially an expansion of the hospital bundle payment programs. It includes a whole set of new specialized care models that would complement medical home initiatives that CMS is very much continuing, and ACO initiatives that again are not mandatory, but that CMS is very much continuing. So I can understand why there's some uncertainty about how exactly these fit together and what organizations have to do. But the voluntary programs that exist now, I think, are going to continue, if not be expanded. I'd also look for a few maybe new directions, putting a more Republican stamp on value-based payment reform, including things like more work through states. So look for waivers, maybe to get more guidance from the administration on how they could support new payment models, or how states could drive multi-payer payment reforms. I'd expect to see more opportunities for consumer involvement, so not just shared savings with providers, but maybe opportunities in Medicare, and especially again in state programs, to use copay changes, value-based insurance design for consumers to get more of the savings when they participate in these new programs. And as a result, some new opportunities coming. Also keep an eye out for what kind of more specific guidance the administration provides on how to do these things. Right now, most of the support for value-based payment from people like Tom Price and Seema Verma has been at kind of a higher level, continuing current voluntary programs, restating their commitment to getting more value in healthcare and enabling and supporting private sector and state innovation. There's more that the administration could do in terms of things like model waivers or financial incentives and support for states and Medicaid, things that Governor Leavitt and I did when we were in the administration back in the last decade that could facilitate these efforts further. So the reforms are going to continue. They're not being touched by the legislation, as Clay emphasized, and I think just a question of how exactly they'll move forward with these new areas of emphasis.
John, could I just comment?
Please.
This is Mike. I think this equation between Medicaid and taxes is going to end up being very interesting. Even if the Senate chooses to not be as aggressive on payment, they're still going to be spreading basically the same amount of money over more states, because the states who didn't expand are going to have an expectation that they just are not left out of the money. So I think you could see more Republican states expand. I think you could see those that don't, looking for some sort of make-do. And so any way you look at it, you're going to be seeing relatively the same amount of money spread over more states, which I think is going to put people in a position where they have to aggressively manage Medicaid. And it's my view, we were talking offline, that a big piece of this could be the Republicans beginning ultimately to see that Medicaid isn't just a discussion of access. It's a discussion of creating an engine to drive value payment out of a sense of economic imperative. So as people see this Medicaid discussion, I don't think they ought to think of it simply as how many people are insured or not, because there may well be an expectation on the part of the Republicans that you keep the same number of people insured, but you just do it in a more efficient way.
And there is a lot that the administration can do to support Medicaid reform, work through Medicaid managed care plans and the like, regardless of what happens with the legislation.
So Seema is obviously a Medicaid expert. Do you expect those things to happen? I mean, she has clear awareness of the possibilities.
She does, and they've already given some general guidance to states through letters emphasizing that they want to see new kinds of care delivery models. They want to see more consumer engagement in care, and you really need payment reform in order to drive that. What I'm seeing around the country, and I'd be interested in the governor's view on this too, is many states now doing more work through private Medicaid managed care plans by things like setting targets or frameworks for episode-based payment reforms or medical homes or ACOs through those plans, with some guidance from the state and maybe involvement of private payers in the states as well. So this is starting to happen now, even before there's a lot more specific guidance from the administration.
And I will add that this whole area of certainty begins to play very big. And by that I mean what the Republicans like about the idea of a so-called block grant wasn't that they like that it's going to make it more certain for them. Well, when that risk is transferred to the state is also going to want to have some degree of certainty. And they're going to look for certainty by passing more off on a managed care basis to managed care plans. And oh, by the way, managed care plans are going to want to have some degree of certainty, and they're going to try to pass that risk off to the providers. So this whole idea of starting at the top with Medicaid, in my mind, this is going to drive value as a discussion, simply because of this appetite for certainty that everyone has, starting with the federal government. If you begin to say Medicaid is not an unlimited entitlement in any way, it drives the value discussion.
Fascinating. No, thanks for getting into that Medicaid area, and we might want to come back to that as questions come in. Mark, what you just talked about, interpreting what we're seeing from the administration, it seems that's not common knowledge. A lot of people don't have those signals that you're seeing of support for value-based payments. And I'm wondering, and Governor, back to you, what does that mean for the market? Are we seeing people pause as they lack that clarity of administration, as they're not moving into accountable care?
I think there is a pause. But I think it's not because there is a belief that this isn't going to happen. I think it's a distraction. I think everyone has been distracted by the question of what is going to occur. And given the uncertainty of what's going to occur, there's just a natural sense that I'm just going to kind of wait and see. I think it's a very unfortunate thing. And I think the administration could, in fact, send a much stronger signal that they intend for this to occur. And if they do, it will have a positive impact. But all of the macro indicators are that the administration clearly believes value has to be part of it. Clay just represented that they're not going to see any change that's going to diminish the interest of Republicans in value-based payment. And I've already made the case that I think diminished resources in Medicaid will be a tremendous driver of a requirement for people to change. So anyone on this call who might be considering pausing, I think that would be a bad decision because the intensity on this will grow, not diminish in the long run.
Mark, you're all over the country talking to all types of providers. What are you saying?
Yeah, I would agree with that. There's certainly a lot of uncertainty out there, but as the governor said, I think that relates a lot to, especially for hospitals and larger healthcare organizations, facing some real questions about what's happening to their total reimbursement in conjunction with the Medicaid reforms being debated. And I would also add that the point about distraction can apply to administrations as much as it applies to healthcare organizations. The administration is very busy now with this extremely controversial and difficult legislative debate around the coverage provisions in the Affordable Care Act. I agree with the governor that would really help move this effort forward if they were able to send some stronger and more specific signals, maybe some models for how states or providers working with states could take new steps in delivering more efficient care for vulnerable populations. A lot of the Medicaid programs involve people who also get other types of government support, which historically hasn't been very well coordinated. Dr. Price has emphasized that he'd like to see more work done on mental health, substance abuse, obesity, behavioral issues, where HHS also provides some significant state funding, often in the form of block grants. And historically, it's been hard to integrate those with Medicaid funding because Medicaid has been this open-ended entitlement. So I know the administration would like to do more in this direction. It's I think just going to be a question of how quickly they can provide additional details and additional clarity. In the meantime, I think there is, as the governor said, a lot that organizations can do and are doing. Many around the country are working with Medicaid plans in their state. They're certainly continuing their efforts within the Medicare voluntary payment reform programs and really moving ahead despite the uncertainty around the coverage provisions of the ACA.
Well, let me take that then again to the reason we're actually on this call with the Accountable Care Learning Collaborative. What role you and Governor Leavitt founded this organization, and with a specific mission. Is that just as relevant today as it was when you started 2 years ago?
Yeah, I'd say it's even more relevant, and just to get more concrete with what the ACLC is doing now, this work on the glide path for how organizations can get from wherever they are to more comfort and confidence and success in new payment models and the new ways of delivering care that those payment models support is more important than ever. I think the good news is that there is more evidence on how to do this successfully. There are more examples that we are uncovering with the work in the ACLC and with the collaborative work that other organizations participating with us in this effort are undertaking, more that we know about how to succeed. And one of the big challenges for implementing payment reform from a policy standpoint is it's hard to go forward if organizations don't have a clear path. So that's where you get a lot of opposition from healthcare providers and others, understandably, that they're being asked to do something new, taking on new kinds of risk or accountability for patient results, and they just don't have the capacities confidently developed in order to do that. So if we really want to get more clarity and more support for the value-based payment reform direction, the kind of work that the ACLC is doing can give everybody more confidence in moving forward.
Governor, you feeling good about this too?
There's no question in my mind that all roads point to value. This is a period of time where the economic, one we haven't talked about, because it seems a bit distant, but the Fed has made it very clear that they're going to raise interest rates. If you raise interest rates, it means that the budget problem that the Congress is working with becomes substantially more challenging. If interest rates over the next, say, 3 years or 4 years were to normalize and go back to a 4% average, it would add about $800 billion to the annual deficit in our budget. Now, we just talked about the fact that they're going to try to save $119 billion in this bill. If interest rates alone were to drive $800 billion in additional expense, that's going to put tremendous pressure on the healthcare spend because it makes up such a sizable component of it. So the smart money here is to recognize that this isn't a political issue. It's an economic imperative. And okay, there may be a delay of a month or two while people get refocused in a new administration. But it would be a mistake for people to conclude that it was a major shift in direction. It's not. This is playing out. I've been recently saying we're 25 years into a 40-year transformation. This is yet another iteration. And the people and organizations that can develop the competencies and start to execute in a much more orderly way are going to be ahead. And that's what we're trying to do with the ACLC is to create that organized approach, the glide path to different outcomes.
You say it's not a political activity, it's an economic, but politics is a big driver. We just saw the president's budget, and it lays out some assumptions. And with all houses, the House, Senate, and White House all being Republican, they were to drive a budget that's based on some of these assumptions. Would that accelerate these economic concerns?
I think that's the important point, that there will be economic pressure. And the degree to which there's economic pressure, the pressure will grow to provide better value for less money, to have better care for less money. The alternative is to have less care, less access, or to begin to say quality doesn't matter. I don't think those are acceptable alternatives to the American people or to the people on this phone. What this is about is creating a uniquely American system, and and that's why I think you have to look at this. Yes, politics is a constant part of this, but underlying it is a very substantial imperative that's driven by economics. Politics goes and comes. Economics stays, and demographics stays. And all of those things say we can't continue to spend 20, 22, 24, 25% of the gross domestic product. Value is the only solution that ultimately allows us to do those things without cutting quality, without cutting access, and that's where we're repeatedly going to come back to.
Thank you. We're getting a number of questions coming in. I want to be responsive to them. One's a little more granular. Mark, I'm going to pitch this your way. Governor, I want to come back to you as being a former secretary of HHS and knowing and maybe how Tom Price is feeling now. Mark, this question is, what should we be looking for in the 2018 proposed rule for the quality payment program? We understand this is imminently being published. Any expectations in that rule?
Yeah, I think you've seen some of the signals already. So a lot of flexibility in CMS trying to meet healthcare providers, physicians and physician groups where they are. So a number of different measures that can be reported in order to comply. Also, probably a reduction in some of the burdens on measures. With everything else going on, I think people may not have been paying as much attention to recent developments at the Office of National Coordinator for Health IT. But the new leadership there is very committed to moving to simpler measures of meaningful use as they're being incorporated in the quality payment system. They're more focused on, are you actually using your IT system to improve care in measurable ways rather than kind of check the box on capabilities and the like. So I think there will be a lot of ways for physician groups to comply. For the people on the phone who are trying to move beyond that, move beyond just participation in NIPS to encouraging and supporting physicians they're working with to getting into alternative payment models, I expect to see some more options coming there too. There are a number of pathways now, not only for ACOs to qualify as advanced APMs and give physicians who are participating a 5% payment bonus, as well as getting out of reporting under the usual MIPS requirements. But also, even if you're not an advanced ACO, you can still continue just reporting your ACO measures for the physicians who are affiliated. So it's a very unburdensome way that's consistent with the payment reforms that many of us in the ACLC are involved in to continue that work and maybe even build on it.
Those programs for APM, is that a push or a pull? Is the industry asking for additional models so they can achieve that advanced APM, or is CMS kind of putting them out to make them more available?
Yeah, CMS is committed to increasing availability. They did that in the last administration. That hasn't changed with the new one. Where the biggest gaps are viewed is in areas of specialized care. So specialists who may not be part of a large ACO system now have only a limited range of APM and advanced APM options. If you're a primary care provider in, say, Medicare Shared Savings Program Track 1 Plus or in the CPC Plus initiative, or if you're participating in ACO, you've got options now. It's for some of the specialty groups that want to get out of fee-for-service payment, don't necessarily want to fully join an ACO, maybe want to get paid through episode models or chronic disease management models or something like that, where there's still some uncertainty, and that is a high priority for Dr. Price. That probably won't be fully resolved in this immediate upcoming rule, but it is a case for both the last administration and the current administration have said over time they want to make more options available.
Thank you. Governor, you've been in Secretary Tom Price's seat. I guess you warmed it up for him in some ways. That's a big organization to run. You run into challenging situations. His experience is different than yours, but what advice would you have appreciated having in a first year as a secretary?
I think first it would be the importance of having a team in place, and I think that's been somewhat problematic, and it may have been part of the reason that there hasn't been a clear statement made on value. They just may be overwhelmed doing. I think that's frankly one of the reasons that they've delayed the bundles, is they just haven't been able to get to the point that they feel like they've looked at that enough, and so the easy thing to do is delay it. The other thing that I believe that Secretary Price will clearly have ascertained by now, I remember thinking, I'm holding the wheel of the most important payer in healthcare in the world. but it didn't take me long to figure out that there were a lot of hands on that wheel, and that you have to take a collaborative approach to this, that there are other federal agencies that have a role in all of this, that the Congress wants to have a voice in this, and that there's different voices within the administration. And so keeping things simple, I think, with a simple set of principles, he and other secretaries will find useful.
No, thank you. Great insights. We're coming to the end of our time here. Mark, why don't I pose another question we received to the line, and then just some closing thoughts from each of you. Mark, question comes in: how can patients help in transformation and reducing costs, shared decision making, et cetera, and shared savings? What can they do?
Well, it's a great question, and there's so many ways for most of the costs involved in our healthcare system. It depends a lot on patients. These are costs associated with chronic diseases, with risk factors, especially in programs like Medicaid, in vulnerable populations, as we've discussed so much on this call, that really are hard to deal with just through traditional medical care itself, that depend on things like access to social and community services and behavioral choices and effective care for substance abuse and mental health issues. There are a number of initiatives that organizations in our ACLC effort are undertaking to get patients more engaged. These include everything from shared decision making to new non-financial incentives to get patients involved in traditionally non-medical services like nutrition programs, behavioral programs, and a key part of the ACLC competency set involves patient engagement. So we really are trying to highlight some of these successful models. I do think, getting to the earlier discussion, there's a patient side to that too, as people have seen around the country, as healthcare costs rise and pressure on Medicare and especially Medicaid spending increases, there is a tendency to shift those costs elsewhere. And there are so many ways in which patients, if they are well informed and well supported, can get their healthcare costs down. What I think the administration could do a lot to advance this effort is in helping patients get more of those savings. If you think about the way that payment reforms have been implemented so far in CMMI, almost all of the initiatives have been focused directly on healthcare providers, not consumers. There's only one of the CMMI initiatives that was about value-based insurance design and enabling people, in the case of that pilot, people with diabetes and some other chronic conditions, to lower their costs if they use drugs effectively, if they adhere to treatment plans. That's an area where, as the governor was saying, as the new administration gets more time and more ability to focus on directions they'd like to see in payment reform, or I think you'll see some reinforcing changes. But patient engagement is really critical for getting to this better, less costly healthcare system.
Great. Final thoughts, Governor?
I see a time in the not too distant future when consumers will play an increasingly robust role. And I think to a large extent that will be in choosing plan alternatives, because it's been demonstrated time and again, whether they're Medicaid recipients, Medicare beneficiaries, or private plan purchasers, armed, as Mark said, with information, consumers become they have a powerful instinct to find value, perhaps a greater instinct than anything else. And I think the system will continue to revolve around that. We're doing the right thing with ACLC because we have a long ways to go to the point that we can service those instincts as well as we can. But I'd like to also thank all of those who have participated in the ACLC effort. Some of you today will be visitors and may not know enough about it. We welcome an opportunity to tell you. We need you. This is a collaborative effort across the industry, and it's for a good purpose.
Thank you. Mark,
Just
anything you'd add?
add my thanks as well. As we've talked about, the fundamentals driving towards a need to deliver higher value care and to change payment systems in order to support that are not going away. The conceptual support for value-based payment reform is still there with the new administration, to the extent that there is some uncertainty about how exactly that's going to happen, how exactly to move forward. I think the role of the ACLC is as a privately led collaborative effort, working closely with CMS and states and others, is more critical than ever. So with everything else going on in the ACLC members' daily lives these days, we really appreciate your taking the time to do this, and we look forward to further progress on this vital journey together.
Great. Dr. McClellan, Governor Leavitt, thank you for your time. An audio recording of this conference call will be available on the member portal, and we'll send a link out in next week's news summary. I'm just flashing up again the upcoming events, webinar, June member meetings or member work group calls, and then, of course, October 4th for our DC member meeting. And mentioned there are a few guests on the call. If you are interested more in the Accountable Care Learning Collaborative, we'd love to talk to you about participation, and you can send an email, members@accountablecarelc.org. Thank you all for your time.